and during this pandemic. So, and actually get that information out on what is happening during this pandemic, what is truth, what we need to pay attention to, and exactly what the experience is like for some of our healthcare workers and our essential workers, our frontline workers. So I racked my brain and I said, well, who do I know? I know a few people in the medical field. And I said, I really want to make sure that people understand what's going on, because I know we have like those conspiracy theorists out there saying nothing's happening. Fortunately for us, we are removed from far removed from the what's happening down in New York City, right? So we don't have that immediate feel or effect from that, the pandemic in the city. So up here, we've only got a few hundred cases and a few deaths across our district and even in the upstate area. Even so, people have died and they still continue to die every day. And it has also increased and put a strain on the capacity of our local healthcare workers and our hospitals. So, and I know everyone's been following the governor for the most part every day, trying to get that update and understand. And even then, it's still kind of far away from us. So I said, I want to make sure that when we speak about what's happening in our neck of the state, that we speak to someone who is local, who has been working on the front lines for some time and actually working with nurses and share her experience and maybe some things that are happening. Sonya here is a good friend of the family. She's worked on many different projects. She's multi-talented and worked on different projects with my daughter. And of course, she was she was the first doctor that I reached out to talk about this. And of course, before I can probably finish typing, she's like, yes, definitely. I will share my experience. And her and I, we kind of had a pre-interview chat and just to feel out and make sure that she's comfortable with certain things that would be asked. Now, I want to say how it's going to go. The first 15 minutes is going to be mostly Sonya and I exchanging. I'll ask a question, she'll answer it, and we'll go back and forth on that. So she's just going to exchange some information that way. And then we're going to turn it over for the last 15, 20 minutes, however long you would like it to go. We're going to turn that over to you, and you can ask her any question that you've just been like, I need to know, is this a thing or whatever? And Sonya will be more than happy to answer that. And as well, if we have any doctors, any nurses, or any other healthcare professionals or workers in our audience, feel free to post anything in the chat room. My team is on, and they will be monitoring the chat room, and we'll make sure that your questions are heard and everything. So with that being said, I need to pull up my questions, and I am going to start asking Sonya questions. So when we first had our chat, I said, okay, I'm going to ask you some really simple things, and it may take you back to your first days interviewing with a hospital. And she was like, yeah, I haven't been asked a certain question. I had asked her that in a long time. But it's just to make sure that for those of us who are showing up, that we understand that she's human just like the rest of us, right? And she experiences things as all humans do, but of course in her unique way. But she has a history, she has a background, and I just want to make sure that you know who she is before we get into really asking questions. And with that being said, my first question is...
Sorry, I just wanted to point out one thing real quick. I'm so sorry about that.
Okay.
Just procedurally, just wanted to let everybody know, folks are going to be on mute for the duration of the call. We would ask, obviously, as Teresa said, if you have a question, put it in the chat box. We are also going to turn off video so that the video can zoom in on Teresa and Dr. Sidhu-Izzo. So yeah, we love your guys' beautiful faces. Nothing to do with that, but we want to make sure that we can get a good video zoom. All right.
And then after all the questions and everything, then we'll turn everything back on, except the audio, because we don't want people, clamoring over each other. But if you have a question, definitely do put it in the chat, And once everything's over, once Sonya finishes with my Q&A, we'll turn the video back on so that she can see, you know, who's who, okay? All right, so first question, very simple one. It's very easy. What is your name?
Gosh, these hard-hitting questions. So I'm Sonya Sidhu-Izzo. I just go by Dr. Sidhu, just my maiden name.
Okay,
Yeah,
that was easy. Next one, very hard question. Where do you work?
Glens Falls Hospital.
Glens Falls Hospital in Glens Falls, New York, for those of you who are watching that are not from New York or not from upstate. So why did you choose, this is where it gets really hard, right? Why did you choose to become a doctor?
So I don't think I ever wanted to be anything else ever. From when I was like 2 years old, we've got pictures of me when I was little playing with dolls and shoving like medication down their throat and stuff. But anyway, I was less holistic as a 2-year-old, but anyhow, I don't think I ever wanted to do anything else. My father was sick a lot when I was a kid, and we visited him in the hospital a couple of times. He actually passed away when I was 10. But I think my interest in medicine was long before that. And I don't really have any other doctors in my family. It's just something I always wanted to do.
Nice, nice. And when you finally decided to become a doctor, what was the field of specialty that you chose to go into?
So it was tough because I liked every rotation I did. I ended up ultimately doing my residency in family medicine because you get to do everything. You know, we did internal medicine, pediatrics, obstetrics, some surgery, which thank goodness I don't do full time. But anyway, so I went into family medicine, and but I work as an internal medicine hospitalist. So I only take care of acutely ill patients in a hospital. And internal medicine refers to basically only adults. So I no longer do pediatrics. I no longer do obstetrics. I did briefly work in primary care for about 1 year and 3 months, about 12 years ago. I really liked it. It was in Ballston Lake, near Charlton, near Scotia and Glenville. But I really missed the excitement of the hospital. And I think at the time I had a small child, and I was doing my MBA, and I just needed a different schedule because I was working all the time. So as crazy as it sounds, the hospitalist job actually had a slightly better schedule for me at the time. And then I also worked for a couple of years at Hometown Health in Schenectady recently, like 2014 to 2017 maybe. Just on Saturday mornings, just doing like walk-in urgent care clinic stuff. And I actually loved that. And I chose that because even though I moved up north to here, I did my residency in Schenectady, and I still feel very much a part of the Schenectady community. So that kind of allowed me to keep my hands in the Schenectady area.
How many years have you worked in the medical field?
So I graduated from medical school in 2001. I've been an attending physician since 2005.
Nice. Okay.
15 years.
And so now I'm going to move on to some of those the questions closer to this pandemic. During this pandemic, where have you worked and where are you working now, especially with COVID patients? So where did you start out at first during the beginning of this pandemic, and where are you at right now?
So I've always worked, you know, at Glens Falls Hospital as a hospitalist. When all of this first started, for about a week, we did outpatient COVID testing at our hospital. And I volunteered to be there for the first 2 days of it. And that was actually, I won't say fun, but it was an interesting experience, maybe a little bit fun. But unfortunately, I had plans actually to do that whenever I was off from the hospital. I was going to keep working in the testing trailer and tent, but we ended up running out of test kits pretty quickly, like after about 5 days. So we had to stop it. Wow. And then since then, we've sporadically started and stopped again. We're doing it now actually at the Warren County Municipal Center in Queensbury. And, but right now we don't have doctors working there right now. So we have nurses that do the swabs. And
so this is kind of this is a question that you know, I didn't ask before, because you mentioned testing. You ran out of testing kits. How many did you guys start with, and how many, yeah, we'll just start with that. How many tests did you start with?
So I think we started with a couple hundred, and then I remember the weekend we started it, Saturday was the very first day we were doing it. I was told we were getting a shipment of about 1,500 test kits on, it was either Monday or Tuesday. And then Monday or Tuesday came around, it turned out our shipment was much less than it was supposed to be. And I heard from friends of mine that work all over the country that the same thing happened to them. They had ordered a certain number and they got like maybe 1/4 of what they had ordered just because supplies were so low. So,
sorry, go ahead.
Go ahead. No, that's it, yeah.
So did you get those test kits from the state? Was it through your hospital and they ordered it? How did that go? Because I know like this thing, right, with tests, we've got lots of tests and everyone's getting tested. And this is not a unique story. Like you said, a lot of people across the country has said that, you know, they had a testing shortage early on. So I know people are probably going to ask these questions.
So I know the hospital initially ordered them from, I guess the CDC, but then,
Okay.
But in New York State, Wadsworth Lab started doing our own tests very quickly. So within a couple of days, I guess. So now we get them from Wadsworth. And at our hospital, we also have a rapid test, which is 45 minutes to get results. I don't think all the hospitals in the area do that. We have that one, then we have the standard test, which takes a few days, like 2 to 5 days to get back. We have a lot more test kits for the standard one. We only got 100 for the rapid test, so it's very coveted.
So for the rapid tests, what is that? Actually, and then we'll go on to the rest of the questions. What is the difference between the rapid test and the 2 to 5 day test?
So they do them exactly the same way. You take a swab, you stick it up your nose, basically as far back as it'll go till it touches the back of your throat. It's very uncomfortable.
Scrubs your brain slightly.
Yeah, we joke we're taking a brain biopsy, but anyway, so it's the exact same test, same swab. The difference is in the reagents and how they run it. So the test kit we have, I believe they only need a few drops, and it's like a point of care testing thing. It's similar to a flu test or a strep test, which are rapid tests as well. Okay. The one that we send to the lab gets processed in a totally different way. I'm not actually sure of the details on how it's processed. Okay. But, sometimes the turnaround has been as little as just 24 hours, which is great. Sometimes it takes, I think, 3 to 5 days. So my husband actually just told me today, he texted me that he got tested Monday and he just got his result today. Oh, today's Friday. That sucks. So yeah, it took a long time for him. But
yeah, so my husband's an essential worker. He works in transportation with CDTA. So he had to get tested and it was a very stressful week. Like they told him about 48 hours and it actually took almost 6 days. And so it was really, really stressful. And luckily, you know, he came back negative, but so many more people are showing up positive in and around the transportation. It's like, I think he's probably going to end up going and get more tested again. How did your husband fare?
Yeah, he was negative. He's a nurse practitioner. He works in an office, and I guess they came in contact with some positive cases. So
yeah, and it's just a precaution. Yeah, it's scary. Let me see. So we went off on a tangent about testing, but that was very important. So my question is, you personally, like, how are you handling this pandemic? And I know we kind of talked last time about kids and the kids not here but there, and your schedule and stuff like that. So how are you handling this pandemic?
I will say it's a lot better now. It's a lot better now than it was 6 weeks ago. When it first started, I think we were all scared. Just walking around the hospital, I work night shift. So walking around the hospital, talking to the nurses, other doctors, I think everybody was a little uncertain about what was going to come, and everyone had this kind of dark mood about them. We were pretty scared, actually, because all the stories we'd heard coming out of, you know, Italy and China and, you know, other European countries, even Seattle, where it hit here first, we were hearing about healthcare workers getting sick and dying. So we were terrified. I actually decided that my responsibility, and I think all healthcare workers feel this way, is not to infect other people when I'm not at work. Because, you know, at work, we're wearing our PPE, our equipment, et cetera. So for the first 2-3 weeks, I never went to the grocery store. I just went to work and home. And home for me is an apartment in Saratoga where I live by myself. I'm separated, actually. My husband lives in Queensbury and the kids are with him. Sometimes they're with me, but during this whole thing, the first 4 weeks, I didn't even see my kids because at the time, Again, it was all uncertain. I was terrified of infecting them. I thought, well, what if they're the whatever percentage that get terribly ill? What if they die? I'll never forgive myself if I made a single person ill, much less my own children. So I didn't go to the grocery store. I didn't go anywhere. I just went to work and home. Fortunately, I worked a lot during the first 4 weeks. I didn't have too many days off. And I say fortunately, because the couple of days I did have off, I was so depressed because I had nothing to do. I was lonely. I would order in food. I would watch CNN, and CNN would give me even more anxiety. And it was interesting. So I will say though, as time went on and I saw what we were dealing with and how we were dealing with it, and we got more PPE. So, the nurses were happier. I was happier. The other doctors were happier. I won't say happier, but satisfied that we had, appropriate protection for ourselves. Things have gotten a lot less dark, I guess. It's still a very serious, illness, of course. And I think over the last 2 weeks, we've had a decrease in the number of cases being admitted and coming in. So it's been slightly reassuring. That's obviously going to change as soon as we start opening up the economy. It's going to shoot way up, and we know that. So, now we're just waiting for when that will be and what will come then. Again, we're not New York City, so we're a lot better off than what's going on down there. I actually have some friends, former coworkers that I work with. One's a respiratory therapist that I currently work with, actually, and a few nurses I've worked with in the past when I was at Ellis Hospital and St. Mary's in Amsterdam. And they're actually down in New York City working now. And the respiratory therapist, Tom, I think, is in New Jersey. And it's interesting hearing from them how it's going. It still sounds pretty overwhelming, actually.
Yeah. And you know what? And I want to circle back to your colleagues and doctors and depression and PPE. Let's get through a couple more questions and then we'll circle back to that PPE, because I know that probably piqued a lot of people's ears because that's all we've been hearing about, right? Besides ventilators and PPE, and we'll come right back to that. So people don't worry. I'm not going to let that one drop. All right. So, speaking about like the beginning, you said that you worked all those hours. Fortunately, you did, because when you got home, you were totally like lonely. There was no one home, and you were eating and watching CNN and being even more anxiety ridden. How, and I know this is an obvious question, but just if you could add something to it, how does that schedule differ from your regular schedule of internal medicine?
So it's actually, the shifts are similar. We basically at my hospital, the hospitalist doctors work 12-hour shifts, either 7 a.m. to 7 p.m. or 7 p.m. to 7 a.m. The only difference is when all this started, the first weekend, they were supposed to be my days off. I worked doing the outpatient testing right outside the hospital. And those couple of for the first couple of weeks, I sometimes, even when days I was supposed to be off, I filled in for other people because they were either being quarantined because of exposure or they were waiting for test results to come back. And again, since I'd made the decision not to have my kids during that time, I was like, well, I've got nothing to do but work. So I told them, I said, hey, if anyone's sick, if anyone's off, just call me in, I'll come work. So I worked more shifts than usual, but our usual schedule is we work about half the month. So like about 14 shifts per month, and then the rest of the time is off. You can work extra shifts if you want. That having been said, while the number of COVID patients was going up, our regular admissions were going way down, and the hospital census actually has been down the last few weeks. So we initially thought we'd need more of us to work, that we'd add on extra shifts, and we ended up having the opposite problem. We, sometimes have too many people working, and so it's been very different than we expected. And that was a little bit scary too, because then we're saying, well, we keep hearing about people's jobs getting furloughed, and we're like, what if the hospital closes down, or which, I don't think would ever actually happen. I'm pretty sure the state, somebody would bail out a hospital if that happened. I say that, but there's a whole St. Clair's thing, but that's 20 years ago.
Oh yeah, that's a whole nother Zoom. Yeah, that's a whole nother Zoom. So,
right.
So you said something, and I want to make sure that this is clarified. You said that the hospital census was down. So is that the amount of patients that were admitted or?
Yep. The amount of patients coming into the ER to be seen, as well as the amount that were admitted. And,
Admitted, okay.
and at first I thought, okay, this is going to be maybe a week or two, people are staying at home, but when they get really sick, they'll come in. And then after about a month, I was like, where are all the sick people? And so actually, when people did start coming in, sometimes they were extremely ill. Like they would come in having heart attack, a stroke, not being able to breathe, getting intubated, even if they didn't have COVID. And so I would say to the community, if you're not feeling well and you need to go to the hospital, please do, because, you don't need to be afraid to go to the ER or stay away, because, if you let it get out of hand, that's a lot worse.
It's going to be worse. Yeah.
Yeah.
Is there anything notable that has happened, like any particular patients? And I know we're hearing stories of people giving birth alone, elderly people coming in with the disease and not having their family by their bedside. Any one story that sticks out and that you feel comfortable sharing with us?
So I think the hardest part for all of us, and I was talking to the nurses that I work with as well, and I think the hardest part for them also is the patients with COVID who are not doing well and they're completely alone without their family. So I've got two things that stick in my mind. Well, actually I've got a few, but the first is my first inpatient who actually passed away. She was very elderly. She was in her 90s, very, very nice lady, but she was at the point in her life where her family always took care of her, and she was used to her daughter being with her 24 hours a day. So whether she was home, whether she was in the hospital, if she went for rehab to a nursing home, the daughter would be at her bedside. So this is the first time the daughter couldn't be there. So I remember going out to the waiting room to talk to the daughter and reassure her. And then when I went back to see the patient, a couple of times I would ask her a question. She'd say, "Oh, you could ask my daughter. She's sitting right here." And I said, "No, she's not sitting there." She goes, "Oh, that's right. I forgot. She can't be here." And I thought, wow, I hope she's only here a short time. I hope,
Things go back to normal for her.
Unfortunately, she actually did end up passing away. And I spoke to the nurses that had her, and they would basically on an iPad allow her to FaceTime her family and speak to her family. But she was used to her daughter being with her physically, like 24 hours a day. So I mean, I think not just for the patient, but for the family, that must have been horrible. So I think that's what strikes me the most, is that people are alone and they don't have visitors, and there are no exceptions. If they have COVID, even if they're dying, there's no exception to the visitor policy. So that's really, really heart-wrenching.
Yes.
Another one that sticks in my mind is we had patients come up from New York City. There was a week or a weekend, I guess, when all the Capital District hospitals had transfers from Queens. One of our patients who came up, he did not speak English, so he spoke Spanish, which there are probably a lot of Spanish-speaking people, usually in other parts of New York State, didn't happen to be here. We had to use a translator phone to speak with him. And of course he came alone without family. And I remember thinking, he's over 100 miles from home. He can barely communicate with us without using a translator phone, which I felt personally responsible for, because 15 years ago, I told myself I was going to learn medical Spanish and I didn't. So, and he was all alone. And so he actually was one of our two patients that got convalescent plasma treatment. But whether it was the time that he got it in the course of the illness or for whatever reason, he actually didn't make it. And that struck me as well, that he not only passed away alone in the hospital, he couldn't communicate with anybody. He was over 100 miles away from home. And I think that's that's the thing, that the human stories that actually devastate us. And I think you can ask any of the nurses I work with, they'll say the same thing. I think that's what really gets us. Like, not the disease itself as much as how it affects patients and their families.
Yeah. And you used the term convalescent plasma. And correct me if I'm wrong, that means those who have contracted COVID but recovered, and what you're using is the antibodies that their bodies created in their blood to then give to patients who are currently affected with COVID.
Exactly. Yeah.
Okay. Just making sure. Okay. And you mentioned New York City. Would you go to New York City if asked?
Absolutely. As long as my hospital could spare me, I would absolutely go. I did actually sign up with a couple of different agencies that in case they need me. What they're looking for right now is specifically critical care doctors in New Jersey. We don't have that many critical care doctors in the United States. As a hospitalist, some of us, do more critical care than others. I do a lot of critical care. So I figured eventually they'll they'll ask for hospitalists who are comfortable doing critical care. But
We're going to do, I think someone just tried to, did I just hear someone try to talk? Was that you, Josh? No, okay, I guess. Okay, and now we're streaming on Facebook just now. Oh, okay. Sorry, I just heard someone speaking. I think it's just Josh tapping on things. And I'm sorry for interrupting. I want to say I'm going to ask a couple of more questions. We've gone a little longer than 15 minutes, but that's important. And then we're going to go to our audience and have them ask you questions or share experience. And I want to go back to PPE. How has that been for you from the start? Not just you, but you and your colleagues, and now. And you kind of said it, but can you explain just a little bit about masks, gowns, ventilators?
Yeah. So we've always been stocked well enough with ventilators. Our ICU is about a 16-bed ICU, and then we have another section that we opened up to use for the COVID patients. We personally did not have a shortage of ventilators, not yet. As far as PPE goes, the first couple of weeks we were in very short supply, and in fact, to wear the N95 respirators, let me actually, sorry, here's an example of one. To wear these, you actually need to be fit tested. So, you go to employee health, they put it on you, they see if there's a leak at all, if air's getting in, air's getting out. And initially they said we couldn't even be fit tested because we didn't have enough respirators to use, because you use one for fit testing, it's wasted, you throw it away.
Yeah.
And they're like, well, we have to use them on the workers need to use them, so we can't even fit test you. So because I was working in the COVID testing trailer, I was able to get fit tested that morning. And I remember being terrified that it wouldn't fit me. And it did. We found one that fit. It all worked out well. Over time, we've gotten more. We had a lot of donations too from the community, which is fabulous. I think initially a bunch of us sort of got the word out, via Facebook and social media that we were short on PPE. And it's amazing. Many of my friends and many other people in the community really came forward, said, hey, I've got a box of these. Can I donate them to you guys? How do I do it? So we had somebody, the director of intake, coordinate that. And we've actually gotten quite a few donations, which is fabulous. Also gloves, regular surgical masks. So that's great. So we're in a much better position now. But what's interesting is we've learned a new skill on how to reuse PPE safely. The N95 respirators usually are meant to be thrown away after each patient encounter. So you see a patient, you wear it, you take off all of your PPE, which is personal protective equipment, your gown, your gloves, your mask, your goggles, your face shield, whatever, you take them off, you throw them away. We're reusing our N95. So usually we will use one for the entire shift, or I've actually been using one for a few weeks now. I've got two that I rotate out, and I've had them for a few weeks. And the way I'm able to do that is I wear a throwaway surgical mask on top of it, and then I wear a shield on top of that. So there's less chance that the N95 will get contaminated. At our hospital, we're also cleaning them at the end of each day. We're disinfecting them using ultraviolet light. So everybody has their own little bag with their name on it. Their mask has their name on it. We turn it in, and then the next day we pick it up again.
Oh, wow.
So it's brand new. We've never done that before. So I guess we'll see how well it works. I did notice the other day, I was speaking to a colleague, that none of the physicians who work in the ER or as hospitalists have gotten COVID yet. So
seems to be working.
Something right? Yeah. That having been said, a few of our nurses have gotten it. So
knock on wood.
It's hard to, I will say, I think the nurses have more face-to-face time with patients. Though.
Yes,
That's
yes.
I mean, when you're doing the swab, it's the nurse doing the swab, and that's a high-risk procedure because the patient isn't wearing a mask for it. You're getting the sample, viral particles are shooting out of the nose. It's a lot higher risk. So I think the nurses and the respiratory therapists, the CNAs, the nursing assistants, the PCAs, patient care associates, they spend far more time with the patients. So I think they're actually at a lot more risk than the doctors are. But, before, like I said, we used to throw away PPE in between patients. We're recycling it. And it seems to be working out. So we've learned a new skill. We always talk about how much money we waste in medicine. So maybe we've now learned how not to waste that much money. We know how to reuse PPE. Maybe going forward, this is the way to go. Save a lot of money, save a lot of resources, who knows? But I'm sure someone's doing a study right now on it, if, you know, that really is feasible. But, you know, we didn't have time to wait for study. We had to just jump in there and do it. So.
Yeah. And sometimes that's how things are found out, how we reimagine or invent new things. You just have to jump in and do what you got to do, especially during a pandemic. I want to ask, so when we talked previously, we spoke about ventilators. There was this whole like few days or a week or so when everyone was like, no, why should we be sending ventilators down there and up here? And I never really heard from like a doctor or a nurse or anything who have been working with these patients, and the need, of course, was there for ventilators, and how they felt about like this becoming some political, you know, upstate, downstate thing. How do you think about, what did you think about that?
So the coworkers and colleagues that I spoke with, we were all fully on board with sending our ventilators where they were needed, because to not do so would mean somebody would die, and that's not something that's acceptable at all. So I mean, you know, if we had excess ventilators and they needed them, we were happy to send them, because then later when we needed them, they would send them to us.
Yes.
You know, we're one big state. Ideally, I would have loved it on the federal level, say like Montana or someplace that didn't need them as much, would send them to New York, and then, you know, 2 months down the line, if they needed them, we would send them to them. But for most of us in healthcare, it's really not political. It's just a no-brainer that if patients need this resource and we have it, we share it, because to not do so would mean somebody might die, and that's absolutely 100% unacceptable. So, yeah.
Yeah. So and I said I would circle back to this about how doctors are handling this. In the news, we have heard about doctors committing suicide and other horrible things. And we spoke about that, right? And you told me actually about your experience with that, not you personally,
right.
Colleague of yours, and how that sparked your research into this. So can you just?
Yep. So over a period of maybe 8 years, I actually lost 3 physician colleagues to suicide. It was when I was practicing in Schenectady County, actually. And one was a fellow resident of mine, and 2 were physicians in the community. 2 of them were within 6 months of each other. And I think that just really, if anything's going to throw you into a dark place, that's something, you know, losing friends and colleagues to suicide is one of those things. So I actually took an interest in physician suicide, depression, healthcare worker depression. I know a few nurses actually that have committed suicide. There are also some that I don't personally know, but I have friends of friends who know people that have, and it's just a horrible thing. And in all of those cases, I remember with the physicians, in one of the cases particularly, I felt almost like all of us, his friends, had failed him, because how, as physicians, when our job is to recognize suicidal tendencies in somebody, did we not recognize this in him? And the only thing I can come up with is that as a physician, he knew exactly how to hide it as well. He knew the right thing to say. I mean, you know, there's certain buzzwords that get you put into like a 24-hour hold, and certain buzzwords that, you know not to say to not be put in a hold. And I'm not going to say what they are, because I don't want anyone to use that trick. But I think because they're in healthcare, they know how not to get flagged, and they end up not getting help. There's also quite a stigma. Still, I mean, this is 10 years ago, I remember thinking about this, and I think it's still this way. A physician that's seeking counseling or mental health care there's a stigma against that, whether from their colleagues, which there really shouldn't be, or just themselves or the community, there really is. And then, you know, you also wonder what constitutes an impaired physician. If somebody has an alcohol problem, a drug problem, they're impaired, they can't do their job. If they have severe depression, that's an impairment as well. So there's all sorts of, I guess there's all sorts of reasons it probably goes untreated in healthcare workers, physicians and nurses,
Yes.
and everybody. So when I heard about the ER doctor in New York City, I did not know her personally. I know one of my friends that's actually on this call did know her personally, and I'm not going to call that person out because I don't want to have to make him think about a horrible thing. But I know people that knew her, and they were all very surprised, because same thing, they said she showed no signs that we consider to be classic signs. And I think there's also probably a factor of post-traumatic stress disorder in this whole thing too, because what we've experienced here is nothing like what they've experienced in New York City. I have a friend who's in charge of an ICU downstate, and the way he said it once, like almost casually, he's like, "Oh, people dying left and right." And I was like, wow, like to just even say that, just to even picture that, it's like, oh my goodness. So, I mean, I think it's a real, I think what they're experiencing there is just horrible. So, I mean, I've seen it on the news. I've heard about it from colleagues. There's just tons of patients. Everybody seems to be ill. It's
hard.
I mean, it's not war. I don't want to say it's war. War is something different. It's horrible as well. Maybe more horrible. I don't know. But it probably feels like that to them. So.
Yeah. Yeah. I want to take this moment, and we're going to start with questions because I see a lot here. And I thank everyone for being patient. I know I said 15 minutes, but this is a very important conversation that needs to be had and heard. And I see you have a lot of questions. Give me a moment. I want to say we have made sure that all of the information for us up here in the 49th Senate District, in Schenectady, Hamilton County, Herkimer County, Saratoga, Fulton County, all of our neck of the state, we made sure that we culminated all of the information that's being put out there, because there's a lot, right? Just listening to Sonya speak about all these different things, there's a lot, and it can be overwhelming. So we put it on one page on the website so that you can just go to one place and you can see everything that you need to know federally, and of course with the local government, with whatever executive orders that the governor has put forward. All of those things, updates on recovered, deaths, testing, all those things are in one place, including if you need help or know of anyone who needs help mentally, who you think may be struggling with suicidal thoughts. We have the mental health hotline. We also have things for your fur babies if you need help with them. We have all of the help numbers and resources that we could gather for the district for everyone. So if you're not sure where to go, you can always go to that page, teresaforsenate.com/COVID-19. And I think, I'm sure one of the team members will put it in there. If you need to speak to anyone, anything, we have those numbers all in one place, so you don't have to go all over the place looking for things. And I just want to say that, thank you, Sonya, for sharing your story. And let me look here. All right, here. Question from Vivian, who lives in Australia.
Cool.
Continent, yes. How do you feel the United States is doing versus the world in flattening the curve? That's a big question. And what do you think could have been done differently? And answer how. Don't feel pressured that you have to answer this perfectly, Sonya. Just, your opinion, and we're okay with that.
So a lot of what we're doing, we're learning as we go along. So we had the benefit of seeing what happened in Asia first and then Europe. Once we saw what was going on in Asia and Europe, I think, I remember Italy and Spain particularly, I think were very dramatic examples of what could happen. And I know my husband is actually Italian. His whole family lives in Italy. So I would hear firsthand from him that, they were on lockdown and the police would arrest them if they were out of the house after 8 p.m. and how terrified everybody was. And honestly, I think initially I didn't think that would happen here. I didn't think we'd go on lockdown. And in retrospect, I have no idea why I didn't think that. That's obvious that we would. But I think, again, we saw what was going on there. We saw what happened in Seattle before it hit New York. So I think once we ultimately started all of these lockdowns, or whatever we're calling them, New York State on pause, I know is the one that we have here. I think once we started that, we've actually done a pretty good job of flattening the curve. And in fact, I watch the governor's update every day, and he shows literally the curve, and you can see that it peaked and now it's getting a little flatter. It's sort of plateauing. That's fabulous. The problem is that as soon as we start going out again, going to businesses, it's going to go way up again. We know that, and we're expecting that. It's given us time, though, to get more resources in order. So initially, you know, we didn't have enough PPE, may not have had enough healthcare workers. Like since then, people that are retired, nurses and doctors, have come back into the field. I actually know a ton of nurses I used to work with maybe 15 years ago in Schenectady who ended up doing something other than bedside nursing. They're working for the health department. They're, you know, doing like telehealth, or they're in a managerial position or administrative position that has nothing to do with bedside nursing. They've gone back into bedside nursing for this, and some of them have gone back to university. So, I mean, that's fabulous. You know, we've had time for companies to make more equipment, make more ventilators, make more PPE. So I think we're in a lot better position now in that we have the supplies. So this delayed our needing the supplies and the personnel, and now we have them. But, you know, the downside is that we know it's going to go up again. We now have the personnel, we may have the hospital beds, you know, or we think we do. But once it goes up again, we're going to have a lot of deaths again too. And that's ultimately, you know, what we'd like to prevent. So I guess to get back to the question, so how are we doing compared to the world? I think we're actually doing a fairly decent job. I mean, I know some states are doing it a little bit differently. I know what's going on in Europe more than any place else. I think we're doing a great job, actually. I'm actually impressed that with all the political pressure, we haven't reopened yet. You know, I too am kind of getting sick of not reopening. I mean, I'd love to, you know, get my hair colored, get my eyebrows waxed, get my nails done, whatever, you know, but if it means somebody's going to die, then no.
Yeah, it can wait, right? Yeah,
that's the bottom line. So, I mean, I haven't worked out in 6 weeks, but so what? You know, I'm
yeah. Oh my gosh.
And my patients are,
yes.
You know, so it doesn't matter. So I think now we're doing a pretty good job. We could have prepared a little bit better. I think once we saw what was coming, and I don't know that it's, I don't know that it's anyone's fault. It may not be our fault. We may not have gotten the whole picture from the other countries. I don't really know.
We don't know. We don't know. Yeah. You don't know what you don't know.
Exactly. Maybe when we saw this coming, if we had started stockpiling equipment, whatever, but I think we kind of did. I think the hospitals pretty much did. And if there just isn't equipment available, you can't stockpile it. I mean, I know some people have said to me, when this whole thing started, I did a couple of Facebook posts about how we needed PPE. And I was like, please, if anyone has any, give it to us. And people said, oh, did you try Amazon? I'm like, of course, but you can't just buy it on Amazon. It doesn't exist right now. I said, yeah. There's stuff now on Amazon you can buy, but a lot of it will tell you it can't be shipped until June. So, come on. So, but again, in a capitalistic society, you think, you know, if it's available, you buy it, but it's just not that easy. So.
Okay, let me see if we have any more.
Just wanted to flag for anyone who may not have been following the chat box or may not know how to get to it. If you can get to the chat box, the little chat icon should be along the bottom of your screen. So including if you're on Facebook Live, feel free to type in a question and Teresa will read it off for you.
Yes. We have from Carmen Lookshire, what is the average stay for those intubated and or being cared for at the hospital? And it was COVID patients that are being intubated and or cared for at the hospital. What's the average stay?
So that's a great question. And I just want to say, hi, Carmen. I know Carmen.
Thank you for your question, Carmen.
So for intubated patients, it's probably about 3 to 5 weeks. I know that sounds extreme, and it is that extreme. Usually in somebody that doesn't have COVID, when they get intubated, we usually expect that intubation or the period of time they're on the ventilator helping them breathe will be a few days, maybe a week. It usually doesn't go past a week because every day they're on the ventilator, they're on medications to paralyze them so they don't move, they're on sedation, that's bad for them. They're not moving, their muscles are getting deconditioned, and their body isn't used to breathing on its own. So it's usually a few days, and then they either come off of it, or if it's not looking good, you may make other decisions. With COVID, it's been different. We've had one particular patient, he's been in the hospital probably 5 or 6 weeks now. He has not been intubated the whole time, but he's been intubated the majority of the time. He got extubated at one point, didn't do well, and got reintubated. So if it were another disease process, let's say it was severe emphysema, you'd think, okay, after this many weeks, he's probably not going to get better. Maybe we consider something else. But the thing is, it's because of a virus. And, you know, we still have hope that if we kick the virus, if his body can clear the virus, then he'll get off the ventilator. So we're seeing patients on vents 2 weeks, 3 weeks, 4 or 5 weeks. this particular patient actually got convalescent plasma treatment as well. And he seemed to do pretty well initially with it. That's when he got off the ventilator. He got the treatment a few weeks ago though. And so I haven't been at work for 2 days. This is my second day in a row off. So I don't know where it stands right now, but he may actually go for a second round of it. I hope he does, because I am emotionally invested in this guy really making it. So I really want him to make it. Actually, there's a couple of patients I'm emotionally invested in that every day I'm like, I shouldn't log into the computer, but I want to know if they're doing okay. So he's definitely one of them. So it's a lot longer than usual. As far as the hospitalization course, we had a couple of young guys. One was 29, one was 33. They did not need ventilators, but they were admitted. They were on oxygen. They were in the hospital a lot longer than I expected. So let's say it was influenza and it was severe influenza. It would be maybe 2 days, 3 days. They were there at least a week and a half, which is an awfully long time for a 29-year-old or 33-year-old to be admitted. Yeah. So it's a lot.
And there's no reason why. Like
the main thing is that, so clearing the virus is basically how you're going to get better. And the course of this just seems to be much longer. It also affects organ systems that aren't affected by your usual respiratory virus. And you get influenza, you know what's going to happen. It's mostly going to be breathing issues. It's going to be tons of phlegm, so you can't breathe, maybe nauseous. With this, it affects everything. It affects the heart. We've seen arrhythmias from this. We've seen heart attacks. We've had people get strokes. We've had people have pulmonary emboli or blood clots in their lungs because they have COVID. So it's doing a lot more things than your average virus will do. Kidney failure, people have ended up on dialysis. In fact, one of our local physicians went down to Queens on a voluntary basis to help for a while. And it was completely voluntary. She didn't get paid. She was 100% a volunteer. And she's a nephrologist. And she said the amount of patients she had on dialysis that had never been on dialysis before, just because of COVID, was amazing to her. So, I mean, it's a very interesting virus. So I want
to clarify a couple of things that the doctor had mentioned. For those of us who are non-medical people, I know the intubation may be something that you're not really understanding, but it's exactly how it sounds. They're putting a tube into, layman's terms, your windpipe to open up the air passageway so that you can breathe easier, because like the doctor said, this virus affects everything and mostly your breathing. And we know that because we've heard about the pneumonia and everything. And you also mentioned something, you said pulmonary
embolism. Yep.
Embolism, but you said emboli. So that's more than one blood clot in the pulmonary arteries. So I just want to clarify that. And she also mentioned nephrologists, and I'm assuming that these are the people who actually work with dialysis patients, and this is their specialty. So they're working on making sure that the dialysis is doing the job that the kidneys can no longer do, and making sure that the patients are reacting positively in that manner, I'm assuming, right?
That was very well explained, actually, yeah.
I told you I'm a teacher, right? So this is why I just want to make sure everyone in the classroom understands what's being said. I don't want anyone being left out, so I just try to explain. And if I get anything wrong, it's been years since I've worked in medicine, so I can't remember everything. Okay, so let me see. We're going to take one or two more questions, and then I don't want to hold you guys up too much longer. I know, let me see, there was one. Do you think, hold up a second, let me scroll up. I have one question from Paul and one from Carmen, and then we're going to say goodnight. And I thank everyone for joining us and listening to Sonya share her experiences. It's a very important conversation that we should be having. I encourage you to ask anyone that you know is a medical professional. Just make sure that it's not the day that they just work 14-hour shift. I made sure with Sonya, I was like, are you available? You can tell me no. But just make sure they had time to rest. But you know, approach someone that you know and ask, I really need to know for myself exactly what's going on. We can't always rely on what's being said through the media or Uncle Bob or Aunt Jane. I think it's healthy and it's totally acceptable to ask a medical professional exactly what is going on, especially if all your questions are not being answered tonight, which I know they probably aren't. I encourage you to do that. I'm a teacher, so I always encourage people to ask questions. Do you think the world will go back to normal, or is this the new normal for every novel virus down the road?
I desperately hope this is not the new normal, but I guess I don't know. So I guess going back to normal, that's a good question. It depends. We had a SARS outbreak, which is also a coronavirus, years ago. We had another one. We went back to normal after those.
Yes, yes.
It all depends, and we're still learning this, on whether this is something that's going to happen, seasonally, annually, like influenza,
Yes.
or if this is a one-shot deal like SARS ended up being. Like, is it something we can eradicate? There's a lot of factors that go into that. We do have an antiviral right now, remdesivir, that you've probably heard about on the news, that's being used. We have actually a ton of other ones, which I can't name them off the top of my head because they have very unusual names.
Yes.
But we actually have quite a few antiviral protocols being studied. Remdesivir is, the main one we're talking about now. We had we've been using hydroxychloroquine. At our hospital, we were using hydroxychloroquine. There have been studies of other anti-parasitic medications like ivermectin. So my point is, if we come up with good treatments, then getting it won't be as scary because we'll have a treatment. If we come up with a vaccine, we can get vaccinated against it. That also won't be as scary. So I don't know how long this will be our normal, though. We keep saying, okay, May 15th, our shelter-in-place thing ends. It's not going to be
This virus doesn't know dates. This virus does not know dates. So
I personally have tickets for about 7 or 8 concerts this summer. It's back. I'm sure they're all canceled, I'm sure. But that's so unimportant in the whole scheme of things, I guess. So.
Yeah. I'll add to that. I think that for the time being, we're going to have to settle in the fact that this may be our new normal for a short time. And a short time, I mean, maybe like a year or so. And that is a short time in the lifespan of a new virus like this, with human contagion and all that stuff. And I want to make a point, and we didn't speak about medication too much, but like the doctor mentioned, there are so many different medications that are on trial, and they're trying, and some may work and all. Human beings are so different. We're so alike, but we're so different. We all react differently to medication. So there may be some patients who may respond beautifully to this medication. A whole slew of those people may react wonderfully to it, but then you get to that percentage, that small percentage, say, no, our body doesn't like that. And then we have to take another route. So just giving a patient medicine is like a crapshoot. You don't know how they're going to react. And especially me, I should live in a bubble. So I know. So it's a whole new ball game, especially individualized, when you individualize the patients and say, okay, how does this patient and this and that. So, I think that kind of adds into, is this our new normal? When we find that consistent way of treating mostly everyone, and we bring that percentage down of those people who react negatively to the treatments, I think that's when we can actually say, okay, we're actually out of the woods, and we can actually start moving back to being normal. And that's from a medical standpoint. Not like political or, regular every day, I'm going to go get my hair done standpoint. So we don't think that way, but we're actually being forced to think that way. Last question, and then we're done. Do you think this will impact the universal healthcare conversation? I'm going to say, yes, it has. So, but go ahead.
Yeah, probably. I would say absolutely. So.
Yes, definitely.
We kind of are almost doing a universal for COVID. So
yes.
All the COVID related testing and treatment the government is paying for. So that's basically what that is.
I'll tell you, with universal healthcare, they're telling for as long as it's been out there and being spoken about, especially with Bernie for over 30 some odd years, 40 years, there's always been that rhetoric, how are we going to pay for it? We're paying for it now, and guess what? We're doing fine. So we've been paying for it for the last 3 months, 2 months or so. So I think we'll be able to handle this going forward on once we get out of this pandemic. So I really appreciate everyone coming and joining the conversation with Sonya. Thank you so much. The website is up. If you want to volunteer, you want to help out. If you have questions for Sonya that you want to ask and you didn't want to ask in front of everyone, you can email me, teresaforsenate@gmail.com, and I will forward that to her. I will not give out her personal information because personal information, but if you have any questions you want to ask her personally, you can definitely forward that to teresaforsenate@gmail.com. Team, please put that out there so that people can see the email, copy, paste, send us a question. And thank you so much, Sonya. I hope we can have another conversation after this, and we can say, hey, guess what? We're doing better, and this is what it's looking like. I'm a humanist, so I'm really optimistic about our next few steps. So thanks, everyone, and have a good night.
Thanks, everyone, for coming out. Have a good one.
Thank you. Hi to all my friends.
Bye. Thanks, Dr. Sidhu.